Good afternoon, everyone, or at least for those in the North American East Coast, and thank you for joining us. My name is Dorina Landa, and I'm the Executive Director of Advancement at the University of Toronto's Temerty Faculty of Medicine. Before we begin today's event, I'd like to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, it is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And it's my pleasure to welcome you to today's installment of Temerty Medicine Talks for what I think is a timely discussion on aging and place. We're delighted to have these virtual opportunities to showcase some of the important work taking place at Temerty Medicine and across our partner hospitals. I hope you enjoyed today's discussion and very much look forward to hosting more talks and events in the future. I'd now like to turn it over to Trevor Young, Dean of the Temerty Faculty of Medicine.
Hello, I'm Trevor Young, Dean of the University of Toronto's Temerty Faculty of Medicine. In September, we announced a landmark $250 million gift from James and Louise Temerty and the Temerty Foundation. As the largest philanthropic gift in Canadian history, it still takes my breath away. Their donation is an investment in our shared vision of the future, one where we'll champion enhanced discovery and collaboration while also striving for excellence through equity in everything that we do. Throughout this series, we're going to tell you about some of our remarkable research and programs that will advance health and healthcare both here in Canada and around the world. To help guide this conversation, we've got André Picard, our good friend and the award-winning health columnist for the Globe and Mail. André, thank you for making time for us and for all the great work that you do.
Well, thank you very much, Dean Young, and to Darina for the land acknowledgement. Welcome to the Temerty Medicine Talk on Aging and Place. As mentioned, I'm André Picard, and I'm the Globe and Mail's health columnist. I'm also the author of a new book called Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders, so I have a particular interest in today's topic. I should mention that the subject today is aging and place, not aging in place, though there will be obviously some overlap. We have a lot of questions about those two issues, so we'll touch on both of them. Anyhow, to help us sort out all this and to delve into this timely and really fascinating topic are two very knowledgeable experts. We have with us today Dr. Sacha Bhatia and Dr. Sharon Straus. You can read their very impressive biographies in the chat window if you click below. Now, if I read the bios myself, we'd spend the whole hour talking about them and not with them. And I want to tap into their knowledge, so I'm going to do that. So let's get right into it, because we have a lot of questions that have arrived in advance. There's going to be some that come in during the talk. So I want to get right to our experts. So I want to start with both of you, Sharon and Sacha, to ask you a rather personal question about aging in place. So I want to ask each of you, where do you want to live as you grow old? Do you want to live in your family home, a retirement home, long-term care? What is your priority? Maybe Sharon, you can start us off and we'll go from there.
Sure, great. So thanks very much. Great question. And as a geriatrician, I must admit I have this conversation a lot with my patient population. And personally, I want to be where I'm going to get the care that I need, and where it's going to be the place where I'm going to have the ability to choose the care that I want. And in particular, want to be able to have support from friends and family involved. And whether that's going to be in my home or whether that's going to be in another type of environment, such as a long-term care home, I don't know where that's going to be, to be honest. I think it's going to be where, at that point in time, where my needs are going to be met. And based on the resources that I would personally have available at that time. So I think those are the things that I would be thinking about, and really with a focus on, having a good quality of life is really what's important to me.
And we'll delve into some of those areas about what's it mean to have appropriate care and what's right for different people. But Sacha, I'll throw over to you. Where do you want to live out your days?
I would say, Andre, I'd love, God willing, to be able to age in my own home. which I think many, Ontarians, Canadians, and actually people all around the world would like to do. Now, that may not be possible for a variety of reasons. My own physical and mental faculties, the needs of my family and those sorts of things. But if I was given the choice and if everything lined up, I would love to be able to spend the days in my own house.
And that's, if you look at the polling, I saw polling recently saying about 90% of people had the same answer of you. Everybody wants to stay at home. But I want to delve into, is it realistic? We have in this country 400,000 people in long-term care. Is it realistic for all those people or for everyone to stay at home as they age? Maybe, Sacha, you want to continue on that with...
Yeah. So I think there are always going to be folks for whom, living out their final days or living out their later years, at home will not be realistic because there are either physical or cognitive, issues that will prevent that from happening, and the care needs would be too great. But I certainly think that the number of people could get closer to that 90% than it is right now. The people who want to stay there. I think that we have created in this country, unfortunately, some dichotomies, right? Where you either, are capable or wealthy enough to live at home and have your care needs met at home, or you are then, or in a retirement home potentially, or then, oftentimes if you, or you're moved to long-term care. And I think there are many other ways that the government, the health system, could support people being able to achieve their wishes, which is to be able to, spend as much time as they possibly can at home. So I think that it won't be possible for 100%. I think it can be possible for a lot more people than we have right now.
Okay. And Sharon, I imagine you have this conversation with a lot of your patients about where they're going to live. What do you tell them? What's realistic for people staying home? What do they need to do?
So I think this is a really critical question because it's going to be different for every person. And I think that one of the things that we need to realize is that the situation now, hopefully, 5 years from now, 10 years from now, it'll be very different, and that people will be able to have more choices of what they're going to be able to do and where they're going to be able to live out the last few years of their life in particular. If you look at the things that are determining where people are doing that now, it's things like Sacha's mentioned. So it's, do they have financial resources? Do they have family and other caregivers who can help them at home? And people who have multiple chronic diseases, who have dementia, the people who are going to long-term care, these are very medically complex individuals who have lots of care needs, where they're needing 24/7 care. And if you don't have, the family, friends, caregivers, financial resources to do that, it's very in the homes right now. If you wanted to stay in your own home, it's very difficult to do that. And so I think these are the conversations that we need to have with people, and that I have with people all the time. Is what's possible with the resources that are available to you at this point in time to allow you to, if you want to be in your own home, to stay in that home versus going into a long-term care setting. If you have high care needs from, cognitive, clinical, functional status, not everybody has the access to resources to be able to do that in the home.
And you use the word that we don't often use in Canadian healthcare. I heard the C word there, choice. Do people have enough choice about where they want to live as they get older?
I think this is one of the key issues is that, I think it's all about trying to provide people with choices. And at this point in time, I don't think that in Canada and certainly in Ontario, we have enough resources to be able to support people to have lots of choices. For people with more financial resources, they have more choices than people who are very limited from a financial perspective. And certainly a lot of the patient population that I see, is on that latter end of the spectrum where they don't have the financial resources. And so they don't have the same resources and choices as somebody who has more financial resources or more family available to them. A lot of the patients that I see, for example, are very socially isolated. They don't have family, they don't have friends, who are going to be able to provide that caregiving support that they need.
Yeah, it's a lot of important issues there with the money, with having help. Sacha, what role can technology play in this? Can technology help people stay at home longer, or is it much more basic?
I think there's certainly basic, big policy questions, that and financial questions Sharon sort of touched on. But I do think, technology can play a substantive role, at least in easing, some of the barriers for people, staying in place. We've seen during the COVID pandemic in particular, the way that technology has fundamentally shifted our delivery of healthcare. I bet most of the people, whether they be watching this webinar, have had a doctor's visit that has either been over the telephone or by Zoom, or have probably chatted with their doctor or nurse, by email or text. So those are things that probably over a year ago were the vast minority of people had done. And so, and the types of models of care that we have seen grow over the past year, like at Women's College, for example, they have been, and a number of hospitals, we have been managing COVID patients at home, while they have managed through their illness, remotely monitoring them. That has substantially reduced the number of people who have come to emergency rooms. So if you take those examples and then you start to extrapolate to think, well, what could that mean, for an older person who's living at home, maybe in a condo in Toronto, or, even in a retirement residence in Oshawa, how could we bring care to the patient rather than forcing the patient, to come to us? The opportunities then around, again, that reduction of barriers that keep people in place, I think there's a lot of untapped potential there.
And do we use the technology well enough? Like when I've traveled around the world, to Nordic countries, they have like automatic pill counters. They have sensors that know if someone's fallen in their home. In Japan, they make lots of use of robotics. Does Canada do enough of this stuff, or do we just sort of funnel people to a home by default?
Yeah, not even close. And so when I sort of said, there's stark choices, it's like basically it's home with some home care, which is people physically coming into your building or into your home to provide nursing support or PSW support, or then it's institutions. But we don't think, as you've said, about expanding our horizons to say, how can wearable technology, like for example, monitoring people in their home, how can that potentially, keep people safe? Falls monitors, ability to connect with nurses and other health professionals quickly when you need it, either through devices, adding and layering those things into somebody's home dwelling, along with good occupational therapy therapists to be able to make sure the home is safe. Those sorts of things can go a long way to, if not avoiding institutionalization, at least delaying it. And I think that's important. The question is not, are you eventually going to end up in a home or not? But it might even be, can we delay that so you can spend as few years as possible, in an institution requiring full care? And I think technology has a role to play in that.
Okay. And Sharon, you mentioned, I see Sharon jump in on that, and then I'll ask you a different question, but jump in.
Yeah, no, I was just going to say, just to follow up on that, I completely agree with Sacha that it's about addressing the barriers and that we can do a much better job around making digital health more accessible to our older population. And in particular, I think COVID has highlighted that even more with the shift to virtual care that's happened as a result of COVID. One of the things, though, that's been highlighted is that there is a segment of our population that doesn't have the same access, and so I think these are quite substantial barriers that need to be addressed, not just on a healthcare perspective, but from a social care perspective, and in particular, thinking about a study that Dr. Jennifer Watt recently led us on with Laura Liu, who's a junior trainee, and this was a project that was funded by the Daniels Foundation, and it looked at what are the barriers to getting a virtual assessment by an older person, and people who were frail or who didn't have a caregiver were substantially less likely to be able to have a virtual assessment, and in particular, even if they did have access to a computer, it wasn't possible to be used. So there's so many barriers that we have to think about and to really make digital health equitable, and so that it doesn't actually expand our health disparities instead of reduce our health disparities. And so I'm totally in agreement with Sacha that we really need to think about what these barriers are. But a lot of times these aren't from the healthcare aspect, they're from the social care aspect that we need to address.
And you're right, COVID made us think a lot differently about digital health. It also made us appreciate, I think, caregivers. You mentioned a couple of times the importance of caregivers. I was looking at StatsCan data recently. There's 7.8 million Canadians who do some caregiving. 10% of them, 780,000, do this more than 40 hours a week. So how essential is that caregiver part of the equation, and what can we do to help them out?
So again, I think this is such an important part of this conversation, because often we talk about the patients, but we don't necessarily talk as much about the caregivers and the incredibly important role that the caregivers play in this. We know that caregivers of people living with dementia, caregivers of people who have multiple chronic diseases, they are at risk themselves of morbidity and increased mortality and increased stress and anxiety. And again, during this past year, we've seen that more than ever. In particular, if you look at people living in long-term care and their families and essential care partners, the incredible stress these individuals have been under. And we know that there are some interventions that we can do to support caregivers and to support caregiver stress. Some of them could be targeted to them, and some of them could be targeted to the patients or the dyad of the patient and the caregiver. And again, one of our amazing geriatricians here at U of T, Dr. Jennifer Watt's leading some work on this, and just actually had a really nice BMJ paper that came out a couple of weeks ago on this, really showing some of the things that we can do to support. And I think it's really critical to make sure that we don't just think about, well, everything can be downloaded to the caregiver, to the family, and they can be the ones that the default, and that shouldn't be the case. And we have to think about how we can optimally support them and support them over time. This isn't a one-off intervention. It's something that needs to be sustained over time.
And Sacha, maybe you could weigh in on that. I know you deal with some older patients with heart disease. Talk about the importance of their caregivers in taking care of them.
Well, I'd like to say, think that, this year in particular has highlighted in many ways a lot of people who do thankless work. And I think caregiving is sort of this, is an example of where you've had people prior to the pandemic and continuing who do work that is not often seen or monetized or quantified in any way, but its value is absolutely, it's invaluable. Sharon's absolutely right. With my patients, many of the people who, for my older, frail patients who get on who facilitate my virtual calls, or even bringing people to appointments and being able to engage, they have to be brought by caregiver. And I think, we do ourselves a disservice in this society if we don't actually make it. It's one of the barriers, caregiver burnout, and the challenges around caregiving is one of the barriers to providing optimal, care for these folks. So I think we have to have policy, solutions in place that support people doing that. And I would just say, ask any, young parent of young children right now who is now faced with, providing care not in school to their kids and trying to do their job. Imagine that as a microcosm of what it would be like to be caring for somebody, you know, an older person 24 hours a day, 7 days a week, who may have cognitive impairment or multiple medical comorbidities. It makes your life much harder. So we have to make it easier for these people, not harder as we are right now.
And any practical things? What kind of practical help can we offer caregivers?
Well, I would say, one thing is, on a policy perspective, I think some of the simple things that we can do, I think we should be paying them. We should be figuring out ways, or at least ways that some of their expenses can be reimbursable. I think I think caregiving is an occupation, and I think we need to treat it as such. I think the other thing that we can do is, from a point of access perspective to the hospitals and to the health services, are there ways that, again, we can make it easier for them, whether it be transporting medical records, access to patient records, access to, health services, as, sort of the substitute decision makers, that removes barriers to allow them, to reduce their administrative burden. I can tell you a lot of caregivers spend a tremendous amount of time in our fragmented healthcare system, getting records from one place to another, making sure that the connections between our healthcare system are made such that these patients don't fall between the cracks. So if we can reduce their administrative burden, I think that would be massively valuable.
Yeah, definitely lots of people choking on paperwork out there that I hear from. So now, Sharon, another issue you mentioned a couple of times that we have a lot of questions about from our viewers is about the money aspect of this. People learn the hard way that this is very costly when you have a loved one to care for, whether you're buying home care, you're paying for long-term care. How do we make this care affordable for people?
Yeah, so I think that's such an important point, because we have to think about, whether it's access to, making sure that people get, access to the appropriate medications, whether they need to be delivered, whether they need to have any special equipment, gait aids, all of those things, any renovations to their homes. It's really taking that holistic approach to that individual and to their needs, and then thinking about, from a financial perspective, what are the resources that we can bring to bear to help offset that. As Sacha said, it's the time from the caregiver, but it's also the expenses that they are often having to provide as well, without the ability to necessarily get reimbursed or be able to write that off or anything. So I think that's a huge component. The time that it takes for them, if they're working full time, for example, are they able to get time off to take their older parent to a physician's appointment, to take their older parent to get a COVID vaccine, to sign up for a COVID vaccine? I'm sure if anybody on the Zoom call today has tried to sign up an older adult for the COVID vaccine, has encountered it's not always the easiest and most straightforward thing to do, right from booking an appointment to downloading the consent form, and if you don't have a printer or anything like that. So all of those things, we have to think about how we can tailor them to the individual, and then think about the financial strategies to really support that.
I might jump in, Andre, just to say that while there is a massive cost, I think there is also what I think society writ large has started to recognize is they've become aware of these issues. I think for a long time, the issue, of nursing home, institutionalization, aging is something that you start to think about a little like later in life. But I can tell you, a lot of my family and friends, who have even young children and are caring for elderly parents, are now who are not institutionalized, are starting to think about these options for themselves. And, because, bluntly, I think our tragedy in long-term care has made a lot of people say, I don't want to go there. And so, rightly or wrongly. And so it has sparked a conversation that I think has even risen to the point of now you have developers, you have a lot of private sector entities that are saying, Well, in the same way that we've disrupted so many industries, the aging industry, if we can call it that, is ripe for disruption. So I do predict that coming out of COVID, you are going to see a number of both public and private options that will be on the table, that will be a combination of affordable, that will have a lot of the elements that Sharon and I have mentioned, both in terms of social supports and digital supports potentially, that will try and address what I think will be a growing market need into the future. And will it totally change long-term care? Probably not. That's a public thing. But there is a massive space between those needing to go into long-term care and the aging population. And I think a lot of industries understand that and are looking at that very hard.
Yeah, I think you're right. I think the boomers are going to vote with their wallets on this one. But is there a danger that we have this growing gap? You know, the philosophy of Medicare is nobody be denied care because they can't afford it. In this sector, in aging, a lot of people get better care because they have more money.
Yeah. I would just say yes. I mean, and Sharon and I both are live to the issues of equity. I think one of the things, again, this pandemic has taught us is that, you know, we despite the idea of Medicare and this notion of a single payer healthcare system, there's tremendous inequity both in terms of access to health services as well as to outcomes. And I don't necessarily think choice has to mean that we lead to inequity. I think you can have a system done properly that a rising tide raises all boats, where everybody does well, but it can also preserve the right to choice for patients of where they want to live and how they want to live out their later years.
Just to echo that, I think that, you know, I always say that there's always silver linings to everything. And one of the silver linings that I think has happened in COVID is that it really has shone light on, you know, the massive health disparities that we have in Canada. And I'm hoping that this means that we can no longer ignore them to the extent that we have, and really focus our attention on making sure that, you know, anything that we do going forward really does ensure that we capture, you know, whether we're actually making a difference in narrowing the gap in the health disparities that we're seeing. And this is why I think healthcare and social care need to be closely connected, and that we can't just think about healthcare in isolation, that it, you know, it includes social care, it includes public health, it includes education. And again, I think COVID has highlighted how interconnected everything is as well, that it's not just about health, it's about social care, it's about public health, it's about education, and how intertwined all of these things are. And why I think, again, it's one of the silver linings. I think it actually is bringing those connections to the forefront.
Yeah, and forcing us to talk about those inequities, as you mentioned. We have a lot of questions. People want some practical information. So I'm going to throw a couple of them to you. Someone is asking, how do you help someone, Sharon, who resists help? You know, people are older, they get older, they need stuff, but they're proud. They don't want the Meals on Wheels. They don't want this and that. What does a caregiver do in that situation?
So this is a common question that I encounter, and I'm sure, you know, many of us on the Zoom call have encountered that in our personal lives as well, when we're dealing with our parents and grandparents and older relatives. And I think, you know, it all comes down to, you know, number one, what does that individual want? You know, they are the decision maker, and they should be the one who you know, is at the forefront. The second thing is we have to think about is, you know, are they capable or not? So are they capable of making the decisions around kind of what they need and what they want? So that's another factor that comes into play, and that leads to a whole other discussion if we don't think they're capable. But if this is somebody who's capable and they're able to tell us what they want, you know, we have to abide by what they want, even if they decide things that maybe we wouldn't necessarily think are safe or we wouldn't necessarily agree with. That is their right. That's their right to choose. And all we can do is let them make that decision. And I think sometimes that's a really, really hard thing to do. And I know sometimes people get really, can get quite frustrated with that. And I think that, sometimes what it also requires is for the caregivers to not allow that frustration to impact the relationship that they have with that person. That person still, needs you in their lives. Whether or not you agree with the decisions that they're making, I think that you just have to keep in mind that that's their choice. It's the same thing when if you have a child, you may not always agree with the decisions that they make.
And where do you draw those lines? So, as someone who's had parents with dementia, they can be going well for a while. When do you stop listening to their desires?
Yeah, so it's really, you always want to think about what, when they were cognitively intact, what was it that they wanted? What were their wishes? When somebody becomes, incapable of making a decision, that's when the POA, the power of attorney, or SDM, can step in and make the decisions. And then you really are using kind of what's aligned with their previous wishes and what's aligned with their best interests. And in particular, if it's something, we always focus on the side of making sure that they're safe. So, if somebody is living with progressive dementia, for example, and they're at risk of wandering, and in fact, maybe they've left the stove on in their house and they've wandered out in the wintertime by themselves and they live alone. If they had a formal assessment and they were declared to be incapable, then we move on to thinking about, well, how do we make sure that they're safe in the home? If that was their wish to stay in the home, how do we optimize the safety in that environment? What are the resources that we can put into place so that somebody is there to make sure, we can deactivate the stove, we can give them Meals on Wheels, we can, have them registered with a wandering protocol. There's things like that we can do. And then, staged, as things progress over time, if there are no additional resources to be able to provide 24/7 care in the home, then we have to think about alternative settings. So it really is very much tailored to the individual.
And Sacha, you're the technology guy on our panel. You know this technology. Can that help people to stay safe? What kind of tips can you offer people? What can they do technology-wise to ensure their parents are safer, they can stay home longer? There's a number of different, obviously, solutions that are out there. TELUS actually has a home monitoring solution. Even like most of the tech companies have, things that have everything from, mobile controlled locks and, alarm system, security cameras. So you can do that. I would say, but to Sharon's question up front, one of the things I would say is not a technology thing, which is we should be talking to our families about what their desires are and wishes are before it gets to the point where we have to guess. So the thing I hope that people take out of this conversation is it's an uncomfortable thing to do. But one thing, again, this pandemic has done is it's forced all of us, I think, to look at our mortality in a different way. And I would say even for younger physicians, being on the front lines, they've started to ask questions about, what's going to happen to me and where should I, and thus do I have my affairs in order? And I think as we get older, it's certainly, I think more important than any technology is communicating with your family about, what do you want to have happen if things change, if your cognitive status declines, if you become unsafe, what are your wishes, particularly as you go into hospital, if you have to go into hospital and, you need certain types of therapies. And I can tell you as a cardiologist, having a conversation with a patient that's end stage of heart failure, for example, and they have not, and having to have that conversation for the first time, it's much harder to have when the person is sitting in front of a very dire situation than it is maybe when you're sitting at your dining room table, with your family and you're in good health to say, let's have that conversation. So I think communicating
with your family, with your power of attorney, with people, to let them know what you want in advance, I think is really important.
Yeah, I think that's a really important message, that those kitchen table conversations are really important. You don't want to make these big decisions in a time of crisis. Now, Sharon, I have another tough question coming from a viewer that I'll throw to you. They're saying, you know, both panelists have said that some people have to end up in long-term care. There's a need for that. So they want you to describe, what's the perfect long-term care home look like? What?
So I think there's a few things. I think one is private rooms. So I think COVID has really highlighted the need for private rooms. Wide hallways, bright lights, green space. So again, from the evidence that we know, that access to green space makes a huge difference for people, so that they can, you know, even if you're inside, being able to see out at green space is huge. And then being able to have access to, you know, ways of exercise and social interactions. You know, so those are really important aspects. And then there's also the model of care that's involved. There's a lot of interesting work that's being done around the optimal model of care, you know, access to, you know, whether it's, you know, how many hours of a PSW, how many hours of a nurse, how many hours of, you know, physio, OT, because, you know, those are not standard. And then it's all the other supports as well: spiritual care, recreation therapy, you know, pharmacy. All of those different aspects, you know, I think to me, you know, really comes up with the ideal long-term care home.
Is it fair to say a long-term care home should actually look like a home and not like a prison? A lot of our places look like prisons, to be honest.
Exactly, it's a home, and I think that's, you know, that's what we have to think about. That, you know, it's not a hospital, it's not an institution, it's not a facility, it's a home. And the people who are in that home are residents. They're not patients, they're residents. And so this is their home. And so, you know, what should a home look like for an older person? It should be similar to what they would expect in, you know, in a non-long-term care home, but being able to have access to the 24/7 care that they need.
And you mentioned that person-centered approach, like responding to needs rather than having this. We have almost an assembly line delivery of care in some homes now.
Exactly, and I think this again is one of the things to reflect on, back to our conversation around health disparities. We have such a diverse population in Canada, and the diversity means that people are going to have different needs, and whether that's language, literacy, culture, you know, all those different factors that we have to think about, and we haven't traditionally thought about that when we're creating long-term care homes. You know, same thing with, you know, gender and all of the compounding demographic factors, so that the homes really do reflect the homes that we need for our older Canadian population.
And Sacha, I wonder if you could expand a bit, like beyond the home, what about communities? How do we make communities more elder-friendly, easier for people to live in?
It's such a great question. So, you know, I think one is having mixed communities, you know, and communities that, you know, one have, you know, that are walkable as an example, but that are clearly accessible. Communities that have, you know, appropriate facilities. So, you know, accessible community facilities, meeting spaces, Sharon said green spaces, you know, that have access to things like pharmacies, groceries, and that sort of thing, that all have the flexibility for, you know, things like home delivery, which is now becoming even more, you know, easy and accessible. But the other thing is, again, is it's like being able to, you know, where we can, again, layer the technology is, you know, there have been, you know, Baycrest and other places have talked about sort of these communities, these elderly communities where you can have, you know, primary care, or you can have even a hospital or nursing home act as a bit of a community hub, so that, you know, people in their homes can be monitored from those places in a way that's non-intrusive. And so again, everybody's care need is different and needs to be personalized. One of the challenges in long-term care is that we've standardized, you know, what people need. Like, does everybody need 4 hours of care or 6 hours of care? And the truth is in your home, as you age, maybe what you need is somebody to check in with you, you know, every day, once a day, or you need a pharmacist to come around, or you need, your needs might be different. And so a community where these things are interconnected, possibly through technology, would allow you to get truly personalized, patient-centered. And I agree with Sharon, it has to be both equitable and at the same time, ethnically, culturally appropriate care. If we, I think that's doable. And if we do that, I think, again, it creates this feeling of home and place that will, I think, reduce the time, it will delay institutionalization.
Yeah, and I'm reminded, as you were speaking, I'm reminded of the great activist Rick Hansen, who always says there's no downside to accessibility. If you make communities accessible for older people, for people in wheelchairs, it benefits everyone, women with kids in strollers, etc. So there's no downside to it. Sharon, I want to come back to you. Another question people are asking, you mentioned the Daniels Foundation a couple of times. They're doing good research. What research do we need to do in this field? What do we know? What do we not know that we need to know?
Gee, gosh, we could fill another full day just talking about that. There are so many potential questions to answer, and I think partly because it comes from the needs of the patients that we provide care for, from the residents in the long-term care homes, from the caregivers, and to really understand how we can optimize the care that they receive, and again, integrating the health and the social care. Some great areas for research, for example, are around the use of social prescriptions. And so how do we optimize social prescriptions for older people, and in particular, when we've talked about optimizing the health inequities that we're seeing. And so thinking about what are the different social prescriptions that we can be using, and what's the optimal dose and formulation of all these different interventions. The digital interventions that Sacha's been talking about. What are the optimal digital interventions? What's the most effective strategy? What are the ways that we can optimize use of virtual assessments by the healthcare team? What's the optimal model of care for people in a long-term care home? What's the optimal model for serving our older patients or older people who are using the shelter system? We in Canada are seeing more and more older adults who are underhoused and who are using the shelter system. And in particular, as a geriatrician, unfortunately, I'm seeing more of that population. And so what are the strategies and interventions that we can do to meet their needs? And then again, related to what Sacha was saying, really understanding, how should these communities be developed and implemented and assessed to really meet the needs of the older adults, as they age through time. And so I think that the number of research questions is really endless. And the opportunity is really now to be able to answer these.
And you're right. I think we could do a whole other hour talking about those opportunities. Last little thing, we're almost out of time, but I understand there's an institute being created to do some of this research. Can you tell us a bit about that before we wrap up?
Yes, no, absolutely. So in partnership, and it was launched about a year ago with the first donation, a kind donation from the Daniels Foundation. And the Aging in Place Institute was launched. And Sacha and I, one of the best things about it is I get to work with Sacha on this, and we've been able to launch it and get a few projects underway to try and address some of these issues that we've talked about today, and really be able to meet the needs of our older patients now, but going into the future, so that everything that we do is focused on tailoring things to patients and their needs, and tailoring it to the needs of the caregivers as well, and answering some of these critical questions.
Great. Well, I want to thank both of you for answering many critical questions today. Hopefully we'll have the opportunity to do this again. Dr. Sacha Bhatia, Dr. Sharon Straus, thank you for being there, taking time out of your busy days to offer your insight and knowledge. And we answered a lot of the questions from our viewers, not all of them, but most of them. And so I want to thank everyone for joining us. We have a great crowd joined us today online this afternoon. And that will officially conclude the Temerty Medicine Talk for today. Please remember, you'll be able to watch watch a recording of this and some of our past events on the faculty's website, and a link is going to be sent to all the registrants in the coming days. Also, you'll see a link to a brief survey in the chat window below, and we'd appreciate you just taking a couple of minutes to provide us with some feedback on today's event, what we did well, what we can do better in the future. So again, thank you for being there, and thank you. We look forward to seeing you at the next Temerty Medicine Talk, which is coming in June. Have a nice day.